hope, in a moment.
Takes a while.
5 seconds.
Virtual to face-to-face.
Then we have to switch off the video and move on to the...
There we go. So I'm going to share with you our experience of outpatient bispecifics and CAR-T delivery. These are my disclosures. And really with this topic, I think the important message is about making sure that the right patient gets the right treatment at the right time. And so what's really important to bear in mind is there isn't a one-size-fits-all approach to this. I'm just going to share with you what we do in Leeds, but there are some differences about how our service runs that means that this is possible that may not be directly transferable elsewhere. I'm going to primarily focus on the bispecific antibodies because this is what we have access to routinely on the NHS, but I've got 1 or 2 slides at the end about my thoughts around CAR-T and what we're doing in our lymphoma CAR-T service that we can transfer across if we do hopefully get access to NHS CAR-T for myeloma. So just a little bit of background about Leeds to give you some context. When it comes to patients, we do see quite high rates of social deprivation and the associated comorbidities that come with that. And we see relatively high rates of frailty even amongst some of our younger patients. And so we have to take frailty into account when we decide how we treat patients. But that is an entire talk in its own right. When it comes to our centre, we have extensive experience managing CRS and ICANS through all of our CAR-T work, but at the time that the early access schemes for these bispecifics were available, there was no local funding for tocilizumab, and so we had to use a dexamethasone-based CRS management system, and this fits in really quite nicely when you're also doing ambulatory bispecifics. And when it comes to treating patients at the right time, like many places, we have capacity challenges when it comes to our elective inpatient beds, but we have a large and actually quite underutilised ambulatory unit and a lot of experience of different ambulatory pathways in haematology. And so right from the very start, we've used ambulatory step-up dosing for our selected low-risk patients. So I'm really going to take you through what we do in the context of a semi-fictional case study, and I apologise, quite a lot of you will have seen this slide before, I suspect. So this is Anne. Anne is 72, and she went through a fairly standard pathway for her myeloma treatment. She didn't respond to Pomdex at 4th line, and so she moved on to elranatamab at 5th line on an early access scheme, and she had ambulatory step-up dosing. So what do? Well, first we do a risk assessment. We think about important disease factors. Is there bulky disease? Are there large plasmacytoma? Are there rapid kinetics of relapse? If yes, we don't consider these patients currently suitable for outpatient step-up, although we are becoming more relaxed about this as time goes by. We also think about comorbidities, which may make CRS more risky, in particular thinking about renal comorbidity and cardiac comorbidity, and I'm much more worried when both of those coexist than when you have one or the other. And then we think about the practical factors. Do our patients live within 1 hour of the treatment centre, or are they able to stay in our hospital hotel? Do they have access to transport? Do they have a carer to stay with them? Do we trust them to both self-monitor at home, but also, crucially, actually pick up the phone and ring us if they're not well? And do we have direct access to a haematology bed base? We developed a patient handheld record that all of our ambulatory patients go through and have an education session with one of our specialist nurses. This has a clear set of instructions for what they must do during the first 10 days of treatment. We ask them to complete home monitoring 3 times per day and to contact us if they've got any temperature, any shakiness in their handwriting, answer yes to any of a list of questions, or in any way feel unwell. We also used a just-in-case dose of dexamethasone that all patients have at home. So if they do have a temperature of more than 38, they take the dose of dexamethasone before they travel to the hospital. And with this approach, we see very little CRS by the time the patient arrives. We don't ask our patients to do a formal CRS score at home, so we don't give them blood pressure monitors or SATS probes, but we do ask them to monitor their temperature. We ask questions that act as surrogate markers for the other aspects of the CRS score, and we use a sentence as our surrogate for the ICANS monitoring. As you've heard, the sentence is what tends to deteriorate first. And then in practical terms, on a dosing day, our patients attend our chemotherapy unit, the dose is administered, and they're reminded to start their self-monitoring. They self-monitor at home 3 times a day, and at the moment attend our ambulatory unit on a daily basis for a formal CRS score and a formal assessment. But we are the pickup rate for CRS with that is practically zero. And so we're beginning to move away from feeling that that's truly necessary. This is repeated on each day throughout their step-up dosing, and then once they've had their first full dose and 48 hours of monitoring after that first full dose, they return to the normal pathways for receiving bispecifics. So what was Anne's experience? Well, she had her first dose without issue. She returned home and was well on the first day. On day 3, at about 8 o'clock at night, she developed a fever and mild confusion just of grade 1. She took her single dose of dexamethasone, came into the hospital and was assessed and monitored overnight with no further recurrence of the fevers, had dose 2 the following day, went home and had the remainder of her treatment as an outpatient without any problems. Now, I don't have time today to go through all of the data that we have about our pathway, but we did present this at BSH earlier in the year. So Rachel Senior, our pharmacist, had an oral presentation about the safety and deliverability of our step-up dosing, and our CNS, Lindsay Hankey, presented on the patient and staff experience. So if that is of interest to you, then these are the 2 abstracts to take a look at. So that was a very brief run through the bispecific side of things and just in broad terms, the practicalities of what we do. I'm just going to use the last few minutes to talk about the CAR-T side of the service. As we've already discussed today, sadly, we don't have CAR-T available for myeloma in the UK, but we are learning a lot from the lymphoma side of the service. I'm a little bit unique, perhaps, in the myeloma world in that I also run a CAR-T service, and so I'm very well placed to be sort of sitting at the transition point of these things. So this information is really based on our lymphoma CAR-T service and what we're doing at the moment around Lysocell, but this will be very easily adaptable to Cilta-cel or Anita-cel if these come along on the NHS, both of which I've used in clinical trials and would very comfortably use on an ambulatory basis. We would risk assess the patients in exactly the same way as I've just described. So our standard pathway at the moment is that we give our conditioning treatment as an outpatient, and we only admit our patients for day of infusion. That's a little bit different from the approach taken by some other CAR-T centres. Our patients currently remain in hospital for 9 to 14 days following their infusion, longer, of course, if they get that ICANS later on, and then they're monitored as an outpatient on a regular basis up to day 28. But what we are moving to do for selected lymphoma patients receiving Lysocell is that we're going to start using the hybrid pathway. And we're actually hopefully treating our first patient on this pathway next week. So patients will have their conditioning, their infusion, and their first 5 days of monitoring as an outpatient. They'll then have an elective admission between days 5 and days 9 when we expect the bulk of the toxicity to occur, and then we'll revert to their outpatient monitoring. And in the fullness of time, we hope to move to a fully ambulatory pathway, as many centres in the US are already doing, but we want to do this in a stepwise fashion. The practicalities of this will be very similar to what we already do with our bispecific antibodies. Our patients will attend the day unit, have the dose administered and start self-monitoring. Our patients will self-monitor 3 times a day at home. They will have daily contact with the CAR-T service and their elective admission on day +5, with direct access to our dedicated hem-onc admissions unit if they become unwell out of hours. The handheld document is very similar, with the exception that we are asking patients to do the full ICANS score. Our patients already do this between days 14 and 28 at home, so we know that patients and their carers are very capable of doing this. And we're also providing patients with an ambulatory monitoring pack so they can monitor temperature, blood pressure and oxygen levels at home. So they will be doing a formal CRS score as opposed to the surrogate we use with the bispecific patients. This is a feasible pathway for us because of our infrastructure and our setup with our large ambulatory unit and the fact that we can avoid A&E or general medicine with our direct admissions unit. And so we're looking forward to seeing how we get on with this, and hopefully I can give you an update in due course. So what are my conclusions? Bispecific antibodies can be safely delivered in the step-up dosing setting as an outpatient. All patients need to be risk assessed. There need to be clear instructions for patients and carers and clear pathways for review and admission. And this will be challenging in centres that rely on admitting patients through A&E or acute medicine. Education for your day unit staff and your admissions unit staff is really important. Ambulatory CAR-T, I would say, is very much in the early days in the UK at the moment, but I would suggest that hybrid pathways offer a very safe starting point, and we would expect these to be fully transferable to the myeloma CAR-T setting, as and when those drugs become available in the UK. And I will leave it there.
Thank you, Francis. Our next speaker is